derived from the chorionic villi later on. But then we enter the placental phase. Okay, and so week 2, we're just starting to call it a chorion because we're just starting to see chorionic villi. Okay, and here we see week 2, the top of this embryonic disc with the neural groove and a little, I don't see any somites either. I guess maybe I believe them. They tell me that that's what that is. But this is going to become the nervous system, isn't it, up here? And week 3, definitely chorionic villi. Week 4, not great pictures, better picture. And we start to see an umbilical cord and a embryonic heart. Okay. And somites, arm bud, umbilical stalk, leg bud. Okay. Week 8, you can start to see eyes, definite eyes. Starts to look human around week 8. Week 12, definitely looking more human, with little hands, chorionic villi, amnion. Okay. At one point, the fetus is covered with fur, which then disappears.
Unless you have my kids.
Huh? I didn't get that. The genital bud eventually differentiates into male or female genitals. Yeah, I just photoshopped that picture, you know, it took me a while. Just kidding. Male or female genitalia, depending on hormonal support, and we'll talk all about that. Okay, we've talked about this. But the development of the heart. The human heart at the outset, resembles a fish heart, which consists of 2 tubes, okay, at one point. And the 2 tubes join. Okay, chambers form. And pretty soon you start to have chambers. Okay. And we start to see an aorta. But blood flow is kind of interesting. And of course, we haven't got to this yet, but there's no reason to circulate the blood to the lungs yet, because the lungs aren't being used, or the digestive system, because it's not being used, or the urinary system, because it's not being used. The mom is taking care of all that. Okay.
Now, what part of gestation does that happen?
Pardon?
What part does the development of the heart happen at what time?
I was trying to think about when this happens. I sort of think it's, you remember those pictures we saw, starting at about week 4, and it didn't look like a couple tubes anymore. At week 4, it was, remember when it protruded from the body? And so I'd say fairly early on, but I can't give you, of course, this is sort of an ongoing process, so it's probably over a period of maybe 8 weeks that the heart develops. That's a good question that I can't exactly answer. So we're going to look at this picture for a while, and I have quiz questions on the ductus arteriosus, and on the foramen ovale, and on the ductus venosus, okay, and the umbilical vein. And we're going to talk a little bit about the so-called fetal shunts. Here, there are some differences in fetal circulation versus newborn circulation. The fetus is not using the lungs or the digestive system or the bladder or any of the urinary system, whereas the newborn is using all of those, okay? From the first time that that baby coughs and it starts using its pulmonary system, and early on, when it takes its first meal, it starts using its digestive system. And so we have so-called fetal shunts. A shunt could be a pipe or some kind of structure that circumvents some other structure. And in the case of the fetus, we want to circumvent the pulmonary system before birth, because the pulmonary system isn't being used. So why send a whole bunch of blood to the lungs, because it's not going to get oxygenated there, is it? Okay. And so why send a bunch of blood to the digestive system, because it's not going to absorb any nutrients, because that's not where it happens. That all happens, all the oxygen and all the nutrients come from the placenta via the umbilical vein. And so, but the umbilical vein doesn't need to go through the liver or any part of the digestive system, because the mom took care of that blood, got that blood in really good shape. And so all the baby needs to do is just use it. Okay? And so up here we see the pulmonary shunt, which consists of two parts. I doubt any of you remember in that heart dissection lab, but it asked us to look at that pig heart and see if we could see a ligamentum arteriosum. When that pig was a little fetus, it possessed a ductus arteriosus, and the ductus arteriosus connects the pulmonary trunk to the aortic arch. The blood normally comes up the pulmonary trunk to the lungs, but because of that shunt, it goes right over into the aorta and never goes to the lungs, and just goes out to the body. So the ductus arteriosus is a pulmonary shunt. It bypasses the pulmonary system. At the time of birth, that artery, and it was hard to see in the pig. I looked for it on several different hearts, couldn't find it. Anyway, these fetal vessels at the time of birth fill in with collagen and become ligaments. And so the ductus arteriosus at the time of birth becomes the ligamentum arteriosum. And they asked you if you could see the ligamentum arteriosum. That's what they asked you for. And boy, there's a little connection between the pulmonary shunt and the aortic arch, and you could imagine that maybe that was the ligamentum arteriosum. So know about the ductus arteriosus and the ligamentum arteriosum. Also, as another part of the pulmonary shunt, there is an opening between the two atria. So when the blood, normally in a normal individual, the blood comes into the right atrium and is pumped to the lungs, isn't it? Okay. But in a fetus, it comes into the right atrium, and there's a hole between the right atrium and the left atrium, and the blood just goes directly into the left atrium and is not pumped to the lungs. At the time of birth, that hole between the two atria fills in. That hole is called the foramen ovale. Must be an oval-shaped hole. Okay. At the time of birth, that fills in with a fossa ovalis. You can see a little depression there. The tissue is a little bit thinner in the inner atrial septum. The inner atrial septum is hard enough to see anyway, and hard enough that I never asked it in lab. But if you look hard enough in a heart, you can find it, and you'll see the tissue's a little thinner right there. A very common, it's called a septal defect in newborns, is where that hole doesn't close, and between the septa called a septal defect. And that's a very common congenital birth, problem. That's gotta be surgically corrected. So that's the pulmonary shunt. Consists of the ductus arteriosus and the foramen ovale, which close at the time of birth. The digestive shunt, here we see the umbilical vein coming back from the mother, and it enters the liver, but it doesn't percolate through any of those, remember those functional units of the liver? It just passes right through the organ. The vein doesn't branch out or anything. It just passes right through and joins the inferior vena cava, and that's called the ductus venosus. Okay, and that's contained inside the liver. You can find that in a real liver, and it's just a ligament, and it's called the ligamentum venosum. The place where it comes out of the bottom of the liver can be seen, and guess what it's called? The ligamentum teres. Remember that? So the umbilical vein, where it enters the liver at the time of birth, collapses and becomes the ligamentum teres, which connects to the umbilicus. And we learned that, and I asked it. Okay. So that's an important digestive shunt. So know about the ligamentum teres and the ligamentum venosum and that stuff. That's the digestive shunt. And that's good stuff. The difference between fetal circulation and newborn circulation, and the so-called fetal shunts that do not exist in the newborn. So the pulmonary shunt consists of the ductus arteriosus and the foramen ovale. The ductus arteriosus connects the pulmonary trunk with the aorta. Okay. Which of the following fetal shunts connects the pulmonary trunk to the aorta? And I give you a list of those structures, and what one do you pick? Ductus arteriosus. Which of the following is an opening? It's a fetal shunt that is an opening between the right and left atria.
Foramen
ovale. Okay. At the time of birth, a flap of tissue folds over it. You wonder what the stimulus is for that, that causes that to happen. I've always wondered that. Okay. The digestive shunt, it's the ductus venosus. This vessel is a continuation of the umbilical vein and carries blood from the placenta, bypassing the liver. Even though it goes through the liver, it doesn't perfuse the liver, if you know what I mean. It doesn't percolate through the liver. And it's just like a straight through pipe. And connecting to the inferior vena cava. At birth, it collapses, becoming the ligamentum venosum. So good information. The umbilical vein, okay, becomes, well, the umbilical vein that's part of it that's outside the liver becomes the ligamentum teres. The part that's inside the liver is called the ligamentum venosum. So there it is again. So know all of the dark, heavy, bold print are the fetal shunts, but know what the fetal shunt becomes at the time of birth. And it's always a word that ends in ligamentum, except for fossa ovalis. Okay, so what do you think parturition is? Birth, absolutely. So here we see a normal vertex presentation. And at the time of birth, the optimal orientation is that the plane of symmetry of the fetal cranium is aligned with the plane of symmetry. The midline of the fetal head is lined up with the midline of the mother, okay? That's not the normal position of the fetus as it rests inside the uterus. It's tilted to the side. But just before birth, the head lines up so that the midline of the fetal head is in line with the midline of the mother. And that optimizes the passage out through what used to be called the birth canal, but it's a little more modern to call it the pelvic outlet. Okay, of course, the uterus is capable of a great deal of distension. As we all know, unbelievable. And it's unbelievable that as distended as it is, it can still contract with a huge amount of force. And we'll see why that is. Okay, the non-pregnant female, and we see the mesentery and the greater omentum and all that stuff. And little teensy 2.5 inch long uterus. Okay, 12 weeks, the uterus is just a little bit distended, but not much. Okay, and we see what happens over the ensuing months. Quite a good deal of abdominal distension. And with a full term situation, you see what happens to the small bowel of the mother and the stomach. And of course, all of that pushes up against the diaphragm and makes breathing no fun. And how anything makes it through the digestive system is beyond me. But yet it's essential that the mother be able to digest her food, because that's going to become fetal nutrients in a while. Okay, so there you see a kind of a dramatic picture, but nonetheless true, of the fetal head. It's kind of hard to tell what's what in there. Little hand, and
Is that the ovary and the embryo off the side?
okay, there's ovary off to the side there, yeah.
Oh.
And transverse colon. So everything's pretty much shoved out of the way. Okay, there's a procedure when there is some doubt as to the suitability of the pelvic outlet. They'll perform a procedure called pelvimetry. Historically it's been done with X-ray, but of course you hate to use X-ray the fetus, but it's often performed when making the decision, are you going to do a C-section or not? And of course, you know how much I like MRI. Here's a beautiful MRI, and you can see the pelvic outlet is basically between S1 and the symphysis pubis, looking at it laterally. And you can see everything looks just fine laterally. Okay, here we see an axial view, and everything looks pretty much okay. Kind of hard to tell though. You could go down a couple slices and it might not look so good. So. Okay, and there's the picture. And of course with MRI there's no radiation. So, big huge advantage. The only damage is the damage that's done to your pocketbook. Okay, so you see here. And I seem to remember that underneath this particular image, they mentioned that they had to give the mom Valium so that the baby would calm down enough to take this picture. So that probably wasn't too good for the fetus. Okay, the head is almost as big as it's ever going to get at the time of birth. grows just a little bit. The eyes are fully as large as they're ever gonna be, and it's the rest of the body that elongates over the growth period. Not too much growth of the head. And of course, we've talked about bone elongation way back last fall. Okay, so there's the head at 8 weeks, is almost as big as the rest of the fetus, of the embryo. Okay, and at 16 weeks, the rest of the embryo has grown a little bit, so the head's only about a third of the volume of the embryo now. So let's see, 3 times 4 is 12. We'd start to call this a fetus now. Okay, and now we see vertex presentation, 36 weeks. This person has not gone into labor though. The baby's head is still tilted to the side, and there's no dilation and effacement of the cervix. Okay, estrogen. So we see some changes happen. Progesterone is the green line, and during about the first half or third of pregnancy, there's more estrogen. The estrogen level, progesterone levels are higher than the estrogen levels, and there's some significance to that. That situation reverses towards the latter part of pregnancy. Progesterone is a uterine depressant. And so you want the levels of progesterone to be higher than the levels of estrogen in the early parts of pregnancy, because you don't want the uterus to become irritable during the early parts of pregnancy. You really don't want it to be irritable until practically the very end. Okay? Estrogen is a uterine irritant. A high estrogen to progesterone ratio induces the onset of what Braxton Hicks contractions, otherwise known as false labor. High estrogen levels at the very end of pregnancy cause uterine muscle cells to present oxytocin receptors. Uterine muscle cells don't always respond to oxytocin. It's only at the end of pregnancy, when they're expressing oxytocin receptors, that they respond to oxytocin and undergo profound contractions. Okay, so everyone's always wondering, what is it that actually initiates birth? Okay, and so the latest is, last I heard, and maybe since this, they've discovered some earlier thing that initiates it. But late in pregnancy, the placenta initiates secretion of CRH. Now, normally, it's the hypothalamus that secretes CRH, but we'll see that other structures in the body can produce it as well. Okay, and CRH is corticotropin releasing hormone. And so this induces the fetal adrenal glands to produce cortisol and another similar glucocorticoid called dehydroepiandrosterone. Okay, the dehydroepiandrosterone is converted to estrogen, and this additional estrogen causes the uterine muscle cells to become more irritable and to present oxytocin receptors. And something we haven't heard before, in addition to presenting oxytocin receptors, they form gap junctions. Gap junctions are junctions in between muscle cells. Where else have we seen them? Only one other place. The heart. The only other type of muscle that has gap junctions. And the heart, of course, can undergo intense contractions. And now that the uterus has gap junctions, so can it. Okay? And so the formation of gap junctions allows perfect electrical communication between all the cells at once, so that the impulse can travel right through, you know, the wave of excitation that causes uterine contraction, can pass through the uterus, you know, almost entirely at once. And so that the uterus can undergo these intense contractions. Okay? So effects of estrogen: stimulates uterine expression of oxytocin receptors, promotes formation of gap junctions, increases uterine irritability, resulting in, to begin with, Braxton Hicks contractions. But that's just the beginning. Okay? And so the whole effect of these elevated estrogen levels at the end of pregnancy is aimed at more intense uterine contractions. Because the uterine contractions have to be profound to eject the fetus from the body. Okay? Finally, the fetus begins to secrete oxytocin. Okay? But this is just the beginning. And this induces the placenta to secrete. Remember what prostaglandins do to the uterus? Make it contract. There's so many things happening to make the uterus contract. Okay? Oxytocin makes the uterus contract. The prostaglandin makes the uterus contract. Okay? Which further enhances the intensity of uterine contractions. Uterine contractions begin at the fundus and sweep down to the cervix in these intense contractions. Towards the latter stage of pregnancies, the estrogen to progesterone ratio increases, so that estrogen is the dominates over progesterone. And so now we see, kind of hard to see much of this picture, but you see that the cervix is totally dilated and effaced. The tissue is very thin, and the aperture is very wide here. They normally say 10 centimeters is desirable. This isn't 10 centimeters, but we can see the amnion start to peek out through the cervix here. This looks like it might be 5 centimeters maybe. So, okay. So relaxin depolymerizes collagen, softening the walls of the cervix and allowing dilation and effacement. But the important thing to remember is that in order to achieve dilation and effacement, you not only need this change in composition of the cervix, but you also need the baby's head. The baby's head is what pushes against that tissue and dilates and effaces it. So when the amnion ruptures, and we know what happens, then all the amniotic fluid runs out. And now the baby's head is in direct contact with those pressure receptors. Remember the pressure receptors that we learned about in the first lecture, fall quarter? Now we're talking about them again in the last lecture of the year. And the baby's head is in direct contact with those pressure receptors. This stimulates the pressure receptors, which are located there. And those pressure receptors send impulses to the hypothalamus, and the hypothalamus releases more oxytocin. Large amounts of oxytocin, which causes more intense uterine contractions, which pushes the baby's head harder. The only problem with this picture is it doesn't show dilation and effacement. Okay. Pushes the baby's head harder, and that causes additional stimulation of the pressure receptors, and the baby's head is pushed harder. And this activity that we call labor consists of dilating and effacing the cervix. Okay, and so now we see the baby's head oriented, the midline of the baby's head is in alignment with the midline of the mother. We see significant dilation and effacement. Okay. Okay. The baby's head plays a pivotal role. That's why you gotta have a vertex presentation. Labor is that period during which dilation and effacement occurs. Easy for me to talk about, but going through it is another matter entirely. The time frame for this process is highly variable, but tends to shorten, I'm told, for most people in subsequent births. Okay. The baby's head not only greatly aids, it's totally essential. So a breech presentation is really quite catastrophic if you plan to have a birth through the pelvic outlet, because you're gonna have to be pulled out with forceps, or dilation and effacement just about can't happen. So, okay, and I don't know where I got this picture. Just to convey the fact that easy to talk about labor, but it's another thing to participate. So we have estrogen from the ovaries and the placenta induces oxytocin receptors on the uterus. Okay, and oxytocin from the fetus and the mother's pituitary stimulates uterus to contract, stimulates the placenta to make prostaglandins, stimulates more vigorous contractions of the uterus, which causes the pituitary to make more oxytocin, and round it goes in the well-known positive feedback loop. Okay, until finally, after we've accomplished dilation and effacement, we get about to the end. Okay, and crowning is when we're just starting to emerge. Okay, and finally, okay, expulsion. Okay, and the final product. And then everybody's happy. So intense uterine contractions continue, because after all, this isn't just going to shut off, and the placenta